we are now going to be having a discussion about the most important and relevant images with respect to the section of endocrinology. Let's get started. Now, looking at this particular image, it shows you the presence of a diffuse enlargement of the thyroid gland. And typically, this is the kind of image that the examiner would be giving to you with a female who is a middle-aged female having a presentation in the form of presence of a thyroid swelling. And then she is going to be having a feature suggestive of hypothyroidism. The moment I talk about the presence of a painless thyroid swelling and feature suggestive of hypothyroidism, the first important thing which would be coming to your mind is going to be quite logically a condition that is going to be given the name of Hashimoto's thyroiditis. Now, Hashimoto's thyroiditis therefore is important for you to be familiar with the fact that there is going to be a diffuse enlargement of the thyroid gland. At a microscopic level, this is an example of a condition which is also being given the name of lymphocytic thyroiditis. So what you have over here is presence of a lymphoid follicle which can be seen over here clearly. So there is presence of a lymphocytic infiltration responsible for the formation of a lymphoid follicle. Additionally, what you are having over here is Hurley cells. When I use the term Hurley cells, I want you to have a look at these cells closely because these are the example of cells which are going to be eosinophilic and they're going to be having the presence of a granular cytoplasm. Please be familiar with the fact, as we talked about in the main videos as well, Hurley cells can also be seen in case of other conditions apart from Hashimoto's thyroiditis, as in case of the follicular tumors. So this is what we need to have an idea so far as Hashimoto's thyroiditis is concerned. Looking at the next example of a condition, this would be coming in the exam with classically history wherein there is going to be a female and then she is going to be having a development of sore throat, because of which then she is going to be having the presence of a painful thyroid swelling. Now, the moment you talk about a female who is going to be having the presence of a fever and then there is presence of a sore throat and then there is a painful thyroid swelling, the first thing that you need to be familiar with over here, this is likely to be a patient who is going to be suffering from decurrence thyroiditis. As and when we make a mention of this kind of a condition, decurrence thyroiditis, you just need to remember the fact that usually patients are going to be having a history of a preceding viral infection. That has a significance in the sense that for this particular condition, the patient is going to be having only a transient trouble. You see, as and when the viral infection is going to get over, it's a self-limiting condition, the thyroiditis of the patient is also going to get better. Microscopically, the condition is going to be characterized by the fact there is a viral infection and therefore you're going to be having the presence of such giant cells, which can be seen quite clearly over here. And what is equally appreciable over here is a presence of follicles which are going to be containing the colloid-like material. So presence of a history of a viral infection, presence of a painful thyroid in a female, presence of such giant cells, presence of follicles which are going to be containing a colloid, all that point towards this one condition, and that is what is to be remembered, decurrence thyroiditis. Treatment is only going to be symptomatic for these patients, as in the administration of something like the NSAIDs, otherwise an example of a completely self-limiting condition. Looking at the next important example of a condition, this is going to be a patient who is going to be a female. She is going to be having the presence of a painless diffuse enlargement of the thyroid, something very similar to what I told you for the very first picture. However, what I can add over here is that this patient is going to be having the presence of features suggestive of a hyperfunctioning thyroid gland, which means that the patients are going to be having elevated values of T3 and T4 and suppressed values of TSS. That's exactly how they presented it to you in the exam. Now, when you're thinking in terms of a hyperthyroidism and you are going to be having the presence of a diffuse enlargement of the thyroid, the commonest condition should be striking your mind. And as and when we are talking about the commonest condition, what is going to become absolutely obvious for majority of you happens to be something like Graves' disease. Now, it is not the clinical picture, neither it is the diffuse enlargement of the thyroid which is going to be so fascinating. But what the examiners are going to be asking question is the histological appearance so far as Graves' disease is concerned. You see, there is a hyperactivity of the thyroid, hyperfunctioning thyroid. So this is going to be characterized by the fact that there is going to be an increase in the number of the follicular thyroid cells. So we use the word follicular hyperplasia. So many cells are going to be present in the thyroid gland that you are going to be having the formation of a papillary structure. I hope you can make out that so far as a papillary structure is concerned. I mean, this is the way the thyroid gland is going to have to accommodate the extra number of cells. Because the cells are hyperfunctioning, so they would take up a larger amount of colloid, and therefore what you find over here is this kind of a whitish area. I hope you can see that streak, complete area adjoining the thyroid follicular cells which are going to be having a whitish appearance. That is what is going to be given the name of a scalloping of the colloid. So I can just make a mention of that particular fact quickly. Follicular hyperplasia, increase in the number of cells. Fact number 2, there is going to be presence of papillae formation, and definitely the whitish areas which are going to be representative of the hyperfunctioning thyroid follicular cells going to be consuming the colloid material over there, and therefore that is going to be associated with scalloping of the colloid. So such a picture, obviously with the clinical picture that I shared with you, female having features suggestive of hyperthyroidism, all going in favor of completely one condition, and that is going to be Graves' disease, what we just need to be familiar with. Looking at the next important example of a condition, this would be a situation in which there is going to be a female who is going to be having the presence of some kind of a neck swelling, and then she is going to be having the presence of a cervical palpable lymph nodes. If at all the history is available, then the history may be suggestive of some kind of history of a radiation exposure. By that, I would be talking about and making a mention of the presence of a thyroid cancer, what is going to be given the name of the papillary thyroid carcinoma. Now, when we are making a mention of the papillary thyroid carcinoma, we just need to be familiar with the fact that this is going to be an example of a condition which is going to be associated with a mutation in the gene called as the red PTC gene. The condition is going to be characterized, as the name gives you a hint, there is presence of papillae formation. So you can just maybe look at the papillae over here, which are going to be seen more beautifully so far as the lower magnification is concerned. And then what you find over here is much more important than the papillae. I wanted to remember that fact quickly. It is not the papillae formation which is going to be characteristic of the papillary thyroid cancer. It is the nuclear finding which is going to be the characteristic feature so far as this kind of a thyroid cancer is concerned. Now, as and when we make a mention of the nuclear findings, three important findings, there is going to be presence of optically clear nuclear material which is going to be associated with the term orphan NEI nucleus. There is going to be presence of invagination of the nuclear membrane, therefore associated with the term the pseudo inclusions. That is what I explained to you quite beautifully in the main video lecture as well. And there is going to be presence of structure which is going to be given the name of a nuclear groove. So the moment you're going to be looking at this kind of nucleus, this optical clearance is given the name of the orphan NEI nucleus, the ground glass appearance. You're going to be having this is a kind of groove that can be appreciated over here, and then you're going to be having invagination of the nuclear membrane, which are going to be given the name of the pseudo inclusions. They are not true inclusions, they are pseudo inclusions. So all that goes in favor of something like the papillary thyroid cancer. Obviously, young patient having a history of radiation exposure and involvement of the spread of the cancer through the lymphatics would be responsible for the enlargement of the cervical lymph node. All that would be going in favor of something like a papillary thyroid cancer. That is what we need to be familiar with so far as this variant of the thyroid cancer is concerned. Now, this variant of thyroid cancer is not to be confused with another important variant in which you are going to be having presence of increased number of the follicular cells. Possibility number one, that you could be having the presence of a benign tumor. So that is what is going to be given the name of a follicular adenoma. And possibility number two, that you're going to be having a situation in which the tumor, as you can find over here, is going to cause infiltration, and it is going to be causing an involvement and invasion of the capsule. So there is tumor which is going to be going outside, and this is what is going to be associated with the follicular carcinoma. Now, why do I make a mention of this particular fact is for the simple reason, fact number one, the follicular thyroid cancer is going to be having an important feature that this cannot be picked up with the help of FNAC. You see, in case of FNAC, as we talked about earlier as well, you are going to be finding only the follicular cells, and that can be seen in both the benign as well as the malignant counterpart. So FNAC is not going to be useful so far as diagnosis is concerned. However, the diagnosis is going to be confirmed on the basis of biopsy, and in the biopsy, this finding becomes critically important because you have to show the presence of the vascular invasion, and these blood vessels are present in the capsule. So capsular invasion of the blood vessels is what is going to be confirming you the presence of the follicular carcinoma. We need to be familiar with the fact that as and when we are making a mention of the FNAC, what is going to be the adequacy of the FNAC is going to be at least there have to be 6 groups of cells, and each of these groups should be having the presence of 10 follicular cells. So that was another important example of a question which was given in the exam. So by and large, when we are talking about the follicular adenoma and the follicular carcinoma, differentiation is done on the basis of biopsy. Fact number 2, whenever we are talking about this kind of a tumor, whether we are talking about a follicular adenoma or a carcinoma, both of them can be having the presence of Hurley cells, as both of them can be having the presence of eosinophilic cells, and there is going to be presence of a granular cytoplasm. So apart from Hashimoto's, these two examples of tumors can also be having the presence of the Hurley cells. The third important variant that we have for the thyroid cancer is what is going to be given the name of the medullary thyroid cancer. Now, when we are talking about the medullary thyroid cancer, that becomes significant because of a whole number of reasons. Fact number 1, this is the only important example of a thyroid cancer which is going to be arising from the parafollicular cells. So it doesn't arise from the thyroid follicular cells, it arises from the parafollicular cells, which are also being given the name of C cells. Therefore, easy for us to understand that one of the important tumor markers which is used for making a diagnosis of this kind of a cancer happens to be calcitonin. Especially in case of a situation when we are talking about the tumor being arising from the parafollicular cells, the extra amount of calcitonin can get deposited in the form of amyloid, which can be picked up over here with the help of that extracellular material which is having a hyaline appearance. Of course, in a routine examination, except for an very experienced pathologist, this is likely to be missed. But to confirm the presence of the amyloid, what we are going to be using over here is the presence of Congo red, and you are going to be using the presence of the apple green birefringence. In case of a situation where a medullary thyroid cancer is going to be not having calcitonin, calcitonin negative medullary thyroid cancer can be picked up with the help of another marker, which is the carcinoembryonic antigen. Why is medullary thyroid cancer also significant? Lies in the fact that this can be associated with the special important condition which is given the name of RET gene mutation, and that can be contributing to the development of multiple endocrine neoplasia type 2A and 2B. I do presume at this point of time when you are watching the rapid revision videos, you are very clear with the fact that MEN 2A syndrome is what is also being given the name of Sippel syndrome. So patients are going to be having 1, pheochromocytoma, 2, they are going to be having medullary thyroid cancer, and 3, they are going to be having the presence of the parathyroid hyperplasia or the parathyroid adenoma. When we are talking about the MEN 2B, which is also being given the name of the MEN 3 syndrome, patients are going to be having the presence of medullary thyroid cancer. They would be having pheochromocytoma, they are going to be having marfanoid habitus, they are going to be having mucosal neuromas. So all those findings are going to be associated with the MEN3. So far as this particular variant is concerned, the variant is associated with amyloid deposition, which can be demonstrated with the help of the important yet commonly used stain, which is going to be given the name of Congo red, and subsequently with the help of polarized microscopy showing you apple green birefringence. We do have a fourth variant of the thyroid cancer, which is going to be the most aggressive one, which is going to be given the name of the anaplastic variant. So those are the 4 important subtypes of the thyroid cancers about which the questions are likely to be asked in the exam. Now, the next important example of a gland that we would like to be highlighting over here happens to be what is going to be given the name of pituitary gland. The normal pituitary gland is important because of the simple fact that you are going to be having 2 populations of cells. So I can talk about the fact that one, there can be example of acidophilic cells, and second, there can be example of basophilic cells. Why that becomes important is, under a normal situation, I mean your and my pituitary would be having the presence of both the cells. However, in case when there is going to be a tumor, we understand the fact in case of tumors there is a clonal proliferation. So one particular type of cells is going to predominate in the affected tissue. What we want to find out over here is that when we are talking about the acidophilic cells over here, they are going to be responsible for the secretion of a hormone like prolactin. They are also responsible for secretion of a hormone like growth hormone. That will become a physiology question. The second fact is, when you're talking about the basophilic cells, they are going to be responsible for the secretion of FSH, they are responsible for secretion of the luteinizing hormone, as well as they are also going to be responsible for secretion of ACTH. So the presence of both the cells is what is going to be seen as a feature of the normal pituitary. Looking about the example of a tumor which is asked in the exam, and that is going to be given the name of a pituitary adenoma, characterized by an important finding. When you see the sheet of the cells over here, they are all going to be appearing similar. So there is one single subtype of the cell which is going to predominate in the tissue. So monomorphic proliferation of the cell. Now the pituitary adenomas can be subclassified into 2 important ways. One way of classifying the pituitary adenoma can be that we can be talking about either they are going to be functional or they are going to be non-functional, or depending upon the size. So what has been asked in the exam earlier is, if the pituitary adenoma is going to be less than 1 centimeter in size, or if it is going to be more than 1 centimeter in size, so that 1 centimeter value is going to be actually the threshold value. Less than 1 centimeter, you would call it by the name of a microadenoma, and whenever the pituitary adenoma is going to be more than 1 centimeter, that is going to be given the name of a macroadenoma. So typically what you need to be able to pick up in the exam is going to be a simple fact that you should be able to understand that if there is presence of just one type of cell, which you can see in the slide with the kind of given history, then that is suggestive of a pituitary adenoma. The next important example of a tumor is what most of you have heard of even in your first years of med schools, that is going to be given the name of a craniopharyngioma. The reason why we heard about craniopharyngioma way too back, as well as we keep on talking about this kind of a tumor, happens to be the fact that its origin is a very important question. So craniopharyngioma is going to be having its origin from a structure that is going to be given the name of the Rathke's pouch. Fact number 2 that we need to be aware of over here with respect to a craniopharyngioma is that this is an example of a tumor which can be seen in either of the age groups. So it is having a bimodal distribution, can be seen in case of a child, can be seen in case of an adult. However, there are going to be subtle differences that we are going to be finding in both the subtypes of craniopharyngiomas. The craniopharyngioma which you are going to be observing over here in the picture is what is going to be seen in the childhood. And this kind of a craniopharyngioma is important because one, it is going to be having the presence of keratin that is going to be given the name of wet keratin. There is going to be presence of concentric rings, concentric keratin deposition, and this is also going to be having the presence of what is going to be given the name of the spongy reticulum. Spongy reticulum. Additionally, please be familiar with the fact that whenever we are talking about childhood craniopharyngioma, which is technically given the name of adamantinomatous craniopharyngioma, this is also going to be having the presence of a peripheral palisading. In complete contrast, any kind of a craniopharyngioma, the adult variant is not going to be having the presence of a cystic mass, which obviously is another important thing that I can make a mention of over here. So yes, there is going to be presence of a cystic mass. The adult variant is not going to be having the presence of a cystic mass. It is not going to be having any kind of a peripheral palisading. It is not having the presence of a spongy reticulum. It's not going to be having the presence of a wet keratin. So keyword to be remembered over here is, yes, you need to be familiar with the origin, Rathke's pouch. You need to be familiar with that kind of a keratin appearance, which is typically associated with the childhood variant or the adamantinomatous craniopharyngioma. And you need to be familiar with the fact that whenever we are talking about this childhood variant, the cystic mass is going to be having the presence of a liquid which is quite rich in cholesterol and lipids. Therefore, that is going to be having an appearance what is going to be given the name of machine oil appearance. Another one-liner hint that is going to be given in some of the exams which can help you crack a question. So machine oil appearance, which is going to be seen in case of the fluid that is present in the cystic mass, is again going to be going or telling you in favor of something like the childhood craniopharyngioma. That is what we need to have idea so far as the two different variants are concerned. Now talking about an example of an endocrinological disorder which is loved by the examiners, especially when they are framing a medicine question, is the one in which an individual is going to be having the presence of hyperglycemia, and that is going to be associated with the development of renal lesions as well. We are referring over here to the condition given the name of diabetes. In case of diabetes, as I've explained you in the ARA section of the kidneys as well, there is going to be the most characteristic lesion which is going to be given the name of the Kimmelstein-Wilson lesion. The Kimmelstein-Wilson lesion is going to be characterized by the fact that yes, you are having the presence of those ovoid large masses which are going to be nodule formation. And the reason why you're going to be having that nodule formation, because there is a hyperfiltration injury, there is going to be extra proliferation or deposition of the mesangial matrix material, and this is going to eventually cause obliteration of the complete glomerulus. So initially there is a nodule which is causing an obliteration. Subsequently, over a period of time, there is a diffuse glomerulosclerosis which is going to be seen in these individuals. Now, the moment we are going to be talking about this kind of a lesion, this is therefore going to be given the name of a Kimmelstein-Wilson lesion or nodular glomerulosclerosis. As we did make a mention of that particular fact earlier as well, that when we are talking about diabetes mellitus, why exactly are we concerned with this glomerulosclerosis? Is simply because of the fact that this condition is going to contribute maximally for the development of chronic kidney disease and subsequently end-stage renal failure in a patient who is going to be suffering from diabetes. We also need to be familiar with the fact that such patients are going to be having characteristically a presence of an amyloid deposition in them, especially when they are going to be undergoing hemodialysis, which is going to be A beta 2. The patients can be picked up with the help of detection of, in the early stages, microalbuminuria, and subsequently, if uncontrolled diabetes is going to be there, then patients are likely to be developing a more massive subtype of proteinuria. So for the given image, the only important point of focus over here is those nodules that you need to be familiar with, which is going to be given the name of the Kimmelstein-Wilson lesion. The next important image which is appearing on your screen happens to be that which is going to be causing an involvement of the adrenal gland, and what you obviously can make out over here is that yes, there is an involvement of the adrenal medulla. So what we are going to be talking about over here is an example of a condition that is going to be given the name of pheochromocytoma. Now pheochromocytoma, as a lot of you should be able to recall and understand friends, is going to be an example of a condition which is going to be associated with the rule of 10. And as and when I make a mention of the rule of 10, I do presume that most of you can quickly recap the fact that this is going to be an example of a tumor in which only 10% of the people are going to be having it on both the sides. Only 10% are having it on both the sides. It is bilateral. It is going to be only malignant in 10% of individuals. Majority of the tumors would be lying inside the adrenal, but then in 10% of the individuals, that can be an example of an extra adrenal location. And usually it is seen in case of adults, but then in 10% individuals, that can be a pediatric presentation as well. The moment we are talking about pheochromocytoma, what we find over here is going to be the microscopic finding, in which we are going to be having the presence of nests of cell, which your books make a mention, and that is what your examiners love to answer. This is going to be given the name of Zelbalan. Zelbalan cells simply means a group of polygonal cells, and surrounding them are going to be presence of the sustentacular cells. So this group of cells is what is going to be given the name of Zelbalan. Why pheochromocytoma becomes also important is because of the fact that this is going to be associated with several types of gene mutations, which can include something like a RET gene mutation, can be associated in a patient suffering from VHL gene mutation, can be seen in a patient who's going to be suffering from a condition that is going to be given the name of Stooge-Weber syndrome. So even that was asked in the exams recently as a question. So far as the red gene mutation is concerned, that is likely to be contributing to the development of the MEN2A, that is the Sippel syndrome, as well as the MEN3 syndrome, for which pheochromocytoma is going to be an important component. Of course, when we are talking about the association with the red gene mutation, they were contributing to MEN2 and MEN3, the VHL and the Stuhl-Weber syndrome. We should not be forgetting over here that yes, it is going to be having a definitive association with the NF1 gene as well, and that is something which you need to be familiar with the fact, because that is what is going to be associated with the von Recklinghausen syndrome. Additionally, we need to be familiar with the fact, as and when we are making a mention of a pheochromocytoma can be responsible for the secretion of catecholamines quite commonly, and then it can also be responsible for secretion of importantly other proteins. Say for example, at times it can be responsible for secretion of something like the vasoactive intestinal peptide as well. We need to be familiar with the fact that it is very difficult for even an experienced pathologist to differentiate between a benign and a malignant pheochromocytoma. So we use the same criteria as we are using with respect to something like a follicular thyroid adenoma and the follicular thyroid carcinoma, which means that you have to demonstrate the presence of metastasis in order to confirm the diagnosis of a malignant variant of pheochromocytoma. So that is what we need to have an idea so far as pheochromocytoma is concerned. The next important image, which is going to be showing you the presence of multiple hemorrhagic areas which are going to be affecting the adrenal gland, and this is going to be an example of a condition which is going to be given the name of the Waterhouse-Friderichsen syndrome. Now, Waterhouse-Friderichsen syndrome becomes important because of fact number one, that it is going to be associated with diffuse septicemia caused because of meningococcal infection. Why this condition becomes important is for the simple fact that this is likely to contribute to the development of adrenal insufficiency. The moment we are talking about adrenal insufficiency, that is going to be associated with multiple causes, out of which you need to be familiar with the fact that if you are talking about the primary adrenal insufficiency, that can be usually because of an autoimmune cause so far as the Western world is concerned. So they would give you an option as autoimmune adrenalitis. However, when we are talking about our country, it is tubercular adrenalitis which is going to be responsible for causing development of adrenal insufficiency. Of course, there can be situations when an individual could be having the presence of an infection, as what we are talking about as of now, and there could be association of adrenal insufficiency with certain types of tumors, say for example the lung cancer as well. All in all, you need to be familiar with the association between Waterhouse-Friderichsen syndrome and meningococcal septicemia, and definitely between the two types of, I would say, geographical regions, tubercular adrenalitis is going to be the commonest cause for adrenal insufficiency so far as the developing world, that is including our country India, is concerned. Talking about an example of a condition which is going to be seen in case of a child, and when the question talks about the fact, that would talk about the involvement of the adrenal gland. What we are referring to over here is an example of a condition in which you are going to be having the presence of a collection of small round blue tumor cells. So obviously with that kind of hint, most of you would be able to recall that the condition I am making a reference to over here happens to be what is going to be given the name of neuroblastoma. Now when we are talking about neuroblastoma, that also happens to be the commonest extracranial tumor in the childhood. Looking at the finding that we have in case of neuroblastoma, you are going to be having a collection of those cells. I hope you can make out the presence of the small round blue tumor cells, and they are going to be arranging themselves in a flower-like pattern around a central area which is going to be consisting of neuropil. So that is what is going to be given the name of a Homer-Wright pseudo rosette. Remember the fact, an example of a true rosette happens to be what is being talked about in association with retinoblastoma, what is being given the name of a Flexner-Winterstein rosette. However, what we are talking about over here is a Homer-Wright pseudo rosette. Neuroblastoma is asked in the exam because of another important reason, because of the fact that it can be picked up with the help of a marker which is going to be neuron specific enolase. It is also can be picked up with the help of a transcription factor that is going to be given the name of FOX2B. There are certain factors because of which a neuroblastoma could be having the presence of a good prognosis, or it could be having the presence of a poor prognosis. Just recalling them one by one. When we are talking about the early stage of a neuroblastoma, that is obviously likely to be associated with a better prognosis. When I talk about the term early stage, primarily I would be making a reference to stage 1, something which should have been discussed with you in pediatrics. We then talk about stage 2A and 2B, and we talk about stage 4S, which is going to be special. However, if a tumor is going to be late stage, that means stage 3 or stage 4, that obviously is going to be having a poor prognosis. As and when we are making a mention of the individual who is going to be having a presentation relatively early, less than 18 months, it is usually going to be having a good prognosis. Any kind of a neuroblastoma in which there is a demonstrated presence of NMYC gene mutation is the one which is going to be more aggressive in nature. So it is the one which is going to be having a poor prognosis. Similarly, if we talk about something like the presence of TRKA, then that is going to be having the presence of a good prognosis. On the other hand, read out the question carefully. TRKB is going to be associated with a poor prognosis. As and when we are making a mention of something like the presence of chromosome 1p, and if you are making a mention of something like chromosome 11q loss, so presence of 1p loss or presence of 11q loss, both of them are going to be associated with poorer prognosis in the affected individual. At a histological level, I must remind you of the fact over here that if there is presence of what is going to be given the name of a Schwannonian stroma, then yes, it is going to be associated with a good prognosis. So primarily, you can remember just one side of the table, and that should be sufficing so far as cracking the question the exam is concerned. So early stage, less than 18 months, Schwannonian stroma on histology, presence of TRK gene expression. Whereas if you are going to be having the presence of late stage 3 and 4, and that excludes the presence of the 4S, you are having the expression of NMYC, you are having the presence of something like the 1P deletion and the 11Q deletion, and you are going to be having the TRKB. All that is going to be associated with the poorer prognosis. So that is what you need to be familiar with. Yes, one of the questions in the PG exam did talk about the chromosomal changes as well. So if you are going to be having the presence of chromosome shattering, that is chromothripsis, that is going to be associated with poor prognosis. Just about one odd question, chromothripsis or chromosome shattering as we use the term. Whereas if you are going to be having the presence of a demonstrated hyperploidy, then yes, it is going to be associated with a better prognosis. So watch out for that kind of a question in the exam, which is going to be asking you something about the neuroblastoma. The signing off thing so far as the endocrinology section is concerned is going to be with respect to the multiple endocrine neoplasia syndromes, because we expect the question to be asked in the exam from them. So as and when we are making a mention of something like the MEN1 syndrome, also given the name of Wermer syndrome, this is going to be an example of a condition which is going to be because of a problem at the level of chromosome 11, and this is going to be characterized by the 3Ps. So there is going to be involvement of the pituitary, the parathyroid as well as the pancreas. That is what you need to be familiar with for the sake of simplicity. When we are making a mention of the MEN2, the MEN2 is going to be given the name of Sippel syndrome. This is going to be seen because of a trouble at the level of chromosome 10, and exactly the same thing is what is going to be seen in case of the MEN3 syndrome as well. The gene that is going to be affected over here is going to be the RET gene. And as I did make a mention of just few minutes back, I'll just repeat that both these conditions are going to be having the presence of the medullary thyroid cancer. They would also be having the presence of pheochromocytoma. However, a question in the exam talking about the MEN2 syndrome or the Sippel syndrome is going to be making a mention of something like the parathyroid hyperplasia that can be seen in case of these individuals, and it can be talking about the presence of certain cutaneous amyloidosis. On the other hand, when we are making a mention of the MEN3 syndrome, there is going to be medullary thyroid cancer, there is going to be pheochromocytoma. The additional finding is going to be a patient who is going to be having the presence of a marfanoid habitus, and the question can make a mention of the fact the patients are going to be having the presence of a mucosal neuroma. So combination of medullary thyroid cancer plus pheochromocytoma plus parathyroid involvement would make a diagnosis of Sippel syndrome. Combination of medullary thyroid cancer plus pheochromocytoma plus marfanoid habitus plus mucosal neuroma would make a diagnosis of something like the MEN3 syndrome. Now, one of the latest and the rarest entities that we need to be having an idea about is given the name of MEN4 syndrome. MEN4 syndrome is quite similar to MEN1 syndrome in the sense that over here also we are going to be having the presence of the parathyroid involvement, as well as there is going to be presence of anterior pituitary tumors. However, the fundamental difference that we have is point 1, MEN4 syndromes are going to be extremely rare, and fact number 2, that in case of MEN4 syndrome you are going to be having the presence of a germline mutation. This germline mutation is absent in case of MEN1 syndrome. So the germline mutation over here is going to be having an involvement of cyclin dependent kinase inhibitor 1B. That is an important thing that has to be kept in mind. So out of the 4 important subtypes of the multiple endocrine neoplasia, the rarest happens to be the MEN4, and you need to be familiar with the fact what exactly are its components, because that is what they can possibly ask in the exam. Not to forget the gene mutation which can contribute to the development of this kind of a syndrome. We also can add on our knowledge with respect to the MEN4 syndrome that patients could be having additional tumors like for example the thyroid tumor, say for example the renal cell carcinoma, say for example the adrenal tumor, which can also be seen in these patients, as well as gonadal tumors. But for the sake of simplicity, MEN1, 3P, pituitary parathyroid pancreas, MEN2, medullary thyroid cancer, pheochromocytoma as well as parathyroid involvement, MEN3, you get medullary thyroid cancer, pheochromocytoma, marfanoid habitus, mucosal neuroma, and MEN4, you are having parathyroid involvement as well as anterior pituitary tumors, and the important finding is germline mutation affecting CDKN1B. That is what is going to take care of the discussion of the endocrinology section.